for taking out time and joining us today for another session of Child Mental Health Community of Practice, and the topic for today's discussion is assessment and management of mental health disorders in neurodiverse children and young people. We would like to start the session today by acknowledgement of country. Northwestern Melbourne Primary Health Network would like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Woi-wurrung people, Boon Wurrung people, and Wadawurrung people. We pay respects to elders past, present, and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. Before formally starting the session, just a quick overview of COP guidelines. So we agree to stay on mute unless speaking. Please raise your hand to speak. Keep conversations confidential. If possible, please keep your camera on. Introduce yourself and your role when speaking, since we are a very diverse community here. Share ideas and promote everyone's participation. Acknowledge that we have varied learning needs and interests, and please feel free to ask any question. Just during the education component, please ask question via the chat box. The session is being recorded, so please ensure that you join the session using the name you registered with so that we can mark your attendance, as we would be unable to issue CPD certificates and points if you haven't really joined in with your name, with the name that you registered. How you can change your name, just a quick overview of that. So if you have joined in using Zoom meeting with an app, you can click on your name. If it's from desktop, you can click on the 3 dots. And if it's from Mac, then hover over your name and click more and then rename, and you're good to go. We have Dr. Prakash with here. He's our consultant psychiatrist. He's a senior consultant child and adolescent psychiatrist at RCH with over 20 years experience. Prakash has worked in and managed general and specialist clinics within child psychiatry in metropolitan and regional public mental health services. He has worked with children and adolescents from 4 to 18 years of age, assessing and managing a variety of mental health issues. I'm Saha, and I'm a GP, and I've been working at Coonawarra Medical Center, and my areas of interest are child and adolescent mental health and chronic disease management. And we have a very special guest speaker today, Dr. Victoria McKay. She's an experienced pediatrician who has worked extensively in the Australian public and private healthcare system. She's the founder of Paediatric People, an innovative private pediatric practice founded on team care, and is one of the founding pediatricians at the Children's Health and Wellbeing Local at Monash Health, where she focuses on health service development. She has worked extensively in a co-consult role in the primary healthcare setting in the Strengthening Care for Children's project. Victoria takes a strength-based, holistic approach to child health, grounded in science and evidence. She's skilled in caring for babies, children, and young people, supporting their development as well as physical and mental health. She has special interest in ADHD. Victoria is a fellow of Royal Australian College of Physicians and graduated with honours from University of Sydney. She qualified as a pediatrician while working at Monash Children's Health and Royal Children's Hospital in Melbourne. And one part that she did not add, that she's awesome. So I'm just gonna look at the agenda here, and then I'm going to hand it over to Vicky. Thanks, Vicky.
Good evening, everyone. It is so nice to join you tonight. Full disclosure, I am joining from a basketball stadium because my 9-year-old has got very important basketball training tonight ahead of his finals on Friday night, and I couldn't get my husband to come home in time. So I am really hoping that the technology goes fine. I'm hotspotting off my phone. Let's see how we go. And let me share screen and bring up my slides. Now, it's really lovely to be online with you guys here. I actually do some similar sort of work to this community of practice in the southeast, where we run a similar sort of community of practice for primary care clinicians. And I'm super passionate about all this stuff. So I'm just so honoured to be able to join you guys tonight, to be a visitor, a fly on the wall to your community of practice. And as Saha said, this sort of stuff, this is really, I love this kind of work, and I really like talking about kids who've got neurodiversity, kids with mental health issues. I had the great fortune of working very closely with Dr. Sahar and a number of other GPs during the COVID years, when I worked in a project through the Royal Children's Hospital, which was called Strengthening Care for Children. And Dr. Sahar, we co-consulted on a number of kids together, didn't we? And that was a really wonderful time and a really interesting insight for me into the kind of work that happens in primary care. And so I have a huge amount of respect for all of you guys who are here in the room tonight. The other thing that I do is probably a little different to many paediatricians, is that I have set up a private practice. That bit's not different. The different bit is that the private practice is founded on shared care, on a team care. So we have general practitioners, nurses and paediatricians in the clinic working together to look after children from a paediatric perspective. We take the work of a paediatrician and we try and do it as a team. So we're based in Elstonwick, but we have families far and wide, including some of the lovely families who I met doing the co-consults up at Goonawarra, who come to see us still. So look, tonight's talk is about mental health in neurodiverse children, assessing and managing it. Now, so you all know I am the kind of speaker who absolutely relishes questions. If you have questions as I'm going along, please put them in the chat. And Dr. Sahar, please feel free to interrupt me and ask those questions, because I really want to make sure that what I'm saying is relevant to people in the audience tonight. This picture is here to be a prompt for me to talk about spectrums, because, I mean, of course, the most famous spectrum that we all talk about is autism spectrum disorder. The autism spectrum, but I think we see spectrums in so many aspects of the complex presentations that we see in children. We see spectrums of ADHD, we see spectrums of gender fluidity, we see children struggling with worries, which in some cases might amount to a formal anxiety disorder, or we see children struggling with low mood, which in some cases might amount to, you know, a depressive disorder. Sometimes when kids come in, you know, like I know that this picture, when you put all those beautiful rainbow colours together, you get pure clear light, but sometimes we don't get rainbows mixed together to form pure clear light. Sometimes when kids come into the clinic, it's a bit more like mixing different paint colors together and it's all muddy, right? And it's sometimes it's really hard to tease out what is going on for a particular child. And I guess it's hard, I want to say it's hard for all of us, and it often takes a bit of time, and it often takes more than one person or one clinician teasing out those issues for a child. DSM-5 is where we draw all of our formalised diagnoses from. But as we all know, there's often so much that's going on for a child and a family and a young person. I see a lot of kids where there's a really significant overlap between neurodiversity and many other different aspects of mental health. When I talk about, I actually really like the word neurodiversity, and although the DSM is the source of truth for mental health disorders, when I'm talking to families, I actually much prefer to think about it in terms of neurodiversity, because there's often so much overlap between kids in terms of particularly the first three A words, autism, anxiety and ADHD. And so many of the kids I see have elements of all three of those, but potentially lots of other things mixed in, like learning disorders, like cognition, like language disorders, like eating disorders. And then there are so many ways in which the child's presentation can be influenced by what's going on in their environment or in their family. So I'm very aware that in our modern Australian society, there's a lot of child behaviour that's now being very highly medicalised. A lot of people talk to me about the really significant wait list to see psychologists, professionals, paediatricians, to get in to see their regular GP. And I think that that is partly reflective. It's reflective of so many things, but in particular, the way we as a culture and a society are now thinking about children's behaviour and children's development. Of course, the things that can make there can be so much going on for a child. And we get a lot of kids now who come to us as paediatricians where the child or the family walks in the door and says, with a medical diagnosis in question, right? They don't come in and say, I'm having trouble with my attention, or, gee, I'm having trouble getting on with the kids at school. They come in the door and say, can you please look at my child because I think they've got ADHD? Or the 14-year-old who walks in the door and says, I think I have autism. Or, yeah, so I guess that's just very interesting for me to think about how we go about approaching and understanding children and their mental health. Now, I reckon that sometimes we sort of start to have these conversations and it can feel pretty stressful and complicated, because as you can see from a slide like this, there can be so much that's going on for an individual child. You know, if we think about a 5-year-old who's grown up in a family where there's been, for instance, family violence or substance use, where the little person's spending too much time on the screen when they're not getting enough sleep, maybe they haven't attended kindergarten, maybe they haven't had healthcare checks, to take that little 5-year-old who's turned up at prep and is not talking to friends, etc., and try and understand what's going on for them can feel sometimes really hard. But what I want to really do is empower you guys with confidence, which is to say that you are all all the people on this call tonight are going to be highly trained clinicians and individuals. And I reckon that this stuff is not rocket science, and a lot of it we can approach in a really common sense kind of way and not rush it and not rush to medical diagnoses. So to actually just try and understand who the child is, what the challenges are that they're experiencing, and try to understand that child in their family. And as you do that, really be thinking about, what are the strengths of this child? What are the strengths of this family? Are there any low-hanging fruit that we can sort of talk about when we think about this child? Now, I'm sure that this kind of graphic will be super familiar to most people on this call, but a lot of children, I think, come to see us because their parents are worried about their behaviour, or their school teacher is worried about their behaviour. You know, they've thrown the chair on the ground, or they've hit the teacher, or they've made a hole in the wall, or maybe this is a little child who's just really, really, really quiet and not connecting with other people. And the first thing that I always do is try to understand in layers what is going on for this child. And sometimes it can take a lot of time, but often starting to understand those first few layers. And certainly, you know, I often defer to my esteemed colleagues in psychiatry. Dr. Prakash, I'm looking at you. Often, once I've got through the first few layers of the iceberg, if I'm trying to tease out, is this autism, is this complex neurodiversity, absolutely I'm referring on to, you know, psychiatry, to the multidisciplinary developmental PEDS teams. But what I reckon is that a lot of the time, simply sitting with a family and a child and talking to them and giving them an opportunity to tell you what is going on is helpful. Because a lot of families come in the door, I guess I think we still get a lot of the externalizing kids referred in, unfortunately, over the internalizers. And what that means is, you know, the kids, I'm sorry, this is probably stuff that you guys all know, so I'm sorry if I'm like saying something you already know, but like the kids who come in who are very aggressive or physical or verbal with their distress, tend to hit paediatricians at a rate of about 2 to 3 to 1, and the 1 being the kids who are sad or quiet or anxious or inattentive. But to actually just pause, just hit the pause button when the family start to launch into the long description of what the child does during the meltdown and how they responded to it and blah, blah, blah. And to actually just go, hey, pause, all right, go back, tell me about the last meltdown, right? And the family goes, oh, well, and you say, no, tell me what happened. And they say, well, he got really angry. And you say, and what happened? What was happening? Set the scene for me. So you're almost getting them to tell the story of their child's behaviour. And often in that, we start to, and then you hear another example and another example. And if the child's old enough, you ask the kid what was going on. Because most kids, even little kids, can tell you pretty well, can't they? And in particular, somewhat, I love seeing neurodiverse kids, because I reckon my neurodiverse patients tell me a lot faster often what's actually going on for them. They're either impulsive and dysregulated, like the little ADHDers who don't really seem to mind too much if they tell you the actual truth, or they've got autism and they tell you straight down the line exactly what they were thinking at particular points in time. And so I think that that's really nice. And so gradually, I think you start to build up a picture where you start to hear 3 or 4 different stories of that child to understand their behaviour, and then start to tease out, hey, this kid is getting really distressed by transitions. Because I think the thing is that I suspect that I'm just going to put it on pause. Sahar, do you mind if I'm just going to send a text message? I'm just going to pause for a second.
Okay, that's fine. Do you guys have any questions in between? Or any comments?
I'm back.
Okay, all good.
Sorry. Yes, if there are any questions or comments, please be sending them through. Dr. Sahar, remind me, where was I up to?
You were just talking about little ADHDers and ASD kids who would tell you everything that's going on.
They tell you absolutely everything that's going on. And that's I reckon that that's really nice. And I think that there's a lot of I think we've probably all got tricks, don't we, in terms of how we get things out of, I think as time goes on, I try different ways of engaging a child and playing with them. And you don't always get it the first time, do you? And I think that was something that I became extremely conscious of the luxury of my appointments, particularly in the private sector, where I get to spend, you know, an hour with a patient on a new appointment. And I know that that is not the reality in general practice on a day-to-day basis. I know that there's a variety of different people in the room, and you probably all have different sort of capacities to do it. But I think that what you can do is you can always make a connection with a child, or make the starts of a connection with a child. And often a lot of the work that I do in appointments is actually, you know, the first 15 to 20 minutes of my 1 hour is actually just making a child and family feel comfortable with me and start to trust me, so that they can then start to tell me stuff. So often that is playing, and often it is drawing. And I reckon that you can do that even, you know, in a scaled down version, in a 10 or 15 minute appointment, where you make the child, because I think families often come in and they just want to take over, don't they? You know, like they just want to start, you know, the parent wants to take control of the appointment and tell you all the things that their child is doing wrong, or all the things that they're worried about for their child. And if we can actually just try and contain them a little bit and hold them a little bit, so that we can actually get the child's voice heard, I find that really useful. I think the other thing I always think about when I see kids who are neurodiverse is just how hard it must be to be neurodiverse in a world which is predominantly neurotypical. And I know that we've made leaps and bounds in the way we think about things. I still like to talk about, and I absolutely have to use the formal lingo in my letters and in my diagnoses. And certainly there can be significant functional impacts from neurodiversity. So having disorder in the title, I do understand the rationale for it. I'm not a heretic in that respect, but I do prefer to talk about things like autism or ADHD without a major focus on the disorder. And I think that that is often important for a child and family, because I personally reckon that a lot of the, now Prakash, I'm so sorry, I might be about to go rogue here and you might have to pull me up on it, but I reckon that a lot of the mental health fallout that young people experience who are neurodiverse comes from a combination of self-esteem, where, you know, I think kids want to feel connected to other humans and they want to feel like they are competent, like they can get on and do things, and they want to have they want to be able to express themselves. And I think those three things can be really hard when you're neurodiverse. So I think the basics of connecting with other children and being understood by them, of being understood in a school. You know, I have a lot of young people who are neurodiverse, and for me, the benefit in coming up with a diagnosis for these young people is often to help schools to understand that young person. Hey, this kid is not being naughty. This kid is not deliberately disobeying you or not trying hard enough. This kid has got ADHD, right? Or this kid has got autism. They're not reacting in this way in order to make a school's life difficult. And so I think the value of a medical diagnosis often comes in that way. But if I can help a family to see their child through my eyes, which is fairly holistically, and I know most families do, but often families get fatigued, don't they? But if we can start to say, hey, you know, like a diagnosis of neurodiversity doesn't have to be something that you have a huge grief reaction to. This can be a description of the strengths and challenges in your child's personality. This can be a description of the way your child's brain works, and help them from the start to go on that journey. Then that can be really helpful, because otherwise I think when a child is misunderstood in a family or misunderstood in a school, or isn't given ways to structure or environment in which they can be their best self or connect with other people, I think that my sense is that that is often where a lot of the distress from neurodiversity comes into play. Now, this slide I shamelessly stole from Dr. Billy Garvey, who presented at the last Community of Practice. So if you came to that Community of Practice, you're probably very familiar with it. And that was because it was such a lovely slide talking about the types of presentations that we are seeing as paediatricians, and talking about the areas in which children are having issues with their development. And with the very sobering statistic which says that 1 in 7 children in Australia have a mental illness, which to me sounds absolutely horrifying. And certainly I'm sure we've all seen that there's been a lot of information in the media recently about just how many children are receiving aids and support in the school environment for having a diagnosis of neurodiversity or a disability in childhood, to the extent that you start to wonder whether or not we are over-medicalising. And I do get the sense that we are probably doing that a little. There are a lot of kids in this world who can't get to see a paediatrician or a psychiatrist. And there are a lot of kids who can see them, but they are going to have to wait a really significant period of time. And I think it's not unusual that in a lot of practices you refer off to a paediatrician or a psychiatrist, and the wait is in the order of months to sometimes 18 months. I've heard of other practices saying, you know, that their books are closed for 2 years. I love food, so you're going to have to excuse the food pictures. But the reason there is a picture of a cake here is to say that I often think that seeing a paediatrician or thinking about things like ADHD medicine, that's often icing on the cake for a child. And the cake, the things that are really important for a child, they are things which people working in primary care are so skilled and so well trained to do. And I guess what I would really want you to have is confidence in the way you go about doing those sorts of things. The other thing I talk about is like low-hanging fruit, right? And so this is where, you know, from a I know that not everybody in the call tonight is a GP, but from a medical perspective, we think a lot about ruling out the obvious medical issues for a child. And so, for instance, making sure their hearing and their vision is okay. And then let's focus on the things that can make a real difference for a child and for a family. So improving sleep is one of the, I honestly think I could spend, if I could get kids sleeping better, that makes such a massive difference individually for the child and for their family members. When a little person is awake until 11 o'clock, 12 o'clock, 1 o'clock, 2 o'clock, 3 o'clock, there is a parent or a caregiver who is also not sleeping properly. And if I can give that parent, if I can help that child with their sleep, they're more likely to have something left in the tank the next day. But their parent is also more likely to have something left in the tank the next day, because so much of a child's behaviour and mental health is a reflection, I reckon, of their parents' mental health as well. Screen time is really interesting. I reckon that I went to a really interesting talk on the weekend at a paediatric conference, which was about screen time. And they presented on the real importance, actually, to a certain degree of screen time for a lot of young people, and in particular for neurodiverse young people. And that's certainly something that I'm very mindful of in my practice. Although for a long time as paediatricians, we have sort of said, you know, no screen time, never, never turn on the computer, never turn on the Nintendo Switch, don't use the phone games. For a lot of neurodiverse young people, playing online in a community of people is a way of connecting with other young people. But there is definitely a line where some is good and too much is too much, a little, everything in moderation. And so understanding what type of screen time the child is using. My personal nemesis is YouTube. I just don't like YouTube. I don't think it does anything good for kids. I don't see how you connect on that or develop competence, etc., etc. It just seems to fuel that drive for novelty and next. Sorry. So how are we going for time?
Really good so far. Yeah, thank you.
When do you want me to finish?
Perhaps around 7:05 to 7:10.
Got it. Okay, good. So what I want to say is that let's go back and address the things that can be addressed. So let's see if we can to get this child sleeping well. And whilst it's really important with things like sleep to think about the parenting practices, the routines in the house, etc., etc., I reckon that melatonin also plays a really valuable role, certainly in the short term, of helping a child re-establish. So I see that as a real adjunct to a child re-establishing a healthy sleep routine. I think building self-esteem is really critical. I think equipping families with supports for their young person is really critical. I see a lot of families who come in who with neurodiverse kids, and the kid is doing umpteen hours of therapy a week and has anxiety and low mood, and so then people want to add in a psychologist, etc., etc. I often talk to families about the importance of the therapist, the allied health support, actually being to teach the parent what they can do. I see the parent as the caregiver, the main caregiver, as the real coach for that child in supporting them to make healthy choices and to develop over time. I love to think about what can be done ahead of time for a child so that when they get to see the paediatrician, they see the paediatrician with as many things on board as possible, so that, for instance, or psychiatrist, but I guess most of the time, a lot of these kids are seeing paediatricians before they might see a psychiatrist. If you can support a child to have some screening tools filled out, if you're suspicious that it's anxiety or low mood, then pick your favorite screening tool. On the next page, I've got a list of the sort of screening tools that are my favorites, but you might have something which is really useful. If we can get qualitative information from school, which doesn't need to be long, it can be like a paragraph, right? And we get some screening tools and we've addressed the low-hanging fruit, then when the kid gets to the paediatrician, we can do the stuff as paediatricians that, that really makes the most of that appointment for that child, so that it's not, the traditional pattern is that it takes 2 or 3 paediatrician appointments before we actually get to the point of sort of making a formalized assessment or diagnosis of a child, or starting a trajectory modifying medicine or putting in place a treatment plan. And that makes me sad, because when a kid waits 12 to 18 months to see someone, and then I say, okay, it's going to take me 3 appointments to help start to sort that out, and that's going to take another 6 to 9 months, that concerns me for a child. I love to be able to progress things as fast as possible. This is here simply as a prompt. I'm going to send all of these out. I know at the end of these talks, you guys have sent out links and information that is thought to be relevant. These are my favourite screening tools for different conditions and different age ranges, and I'm very happy to send those out to the team. And these are the sorts of things that I really love or find useful, and good recommendations. I find good quality information, like from the Raising Children Network, useful. And I love, for instance, things like a lot of families, when they come to us, their own mental health is really affected by the concern they have for their child, so that often there's a lot of really significant anxiety that walks into the room, which is not the child's anxiety, it is the parent or caregiver's anxiety. And so if we can put in place sensible things to help a family feel confident that their child is being well managed before they hit the paediatrician, then I think that's really useful, because then that starts to influence the way the child presents as well. So big shout out to Raising Children's, big shout out to the health pathways. I know that those resources are really great. Harriet Hiscock, who is a bit of a guru at the Royal Children's Hospital, paediatrician in community child health, who many of you will probably have heard of, has this marvellous website called Sleep with Kip through the Murdoch Children's Research Institute. And this has got a really lovely quiz that families can answer about their child's sleep to help individualise it for their child. And this, I'm almost finished, Sahar, but this slide is just to talk about why I, as a paediatrician, get really excited about actually diagnosing and treating, for instance, ADHD. I think in particular for ADHD, we know that medicine is still icing on a cake, but sometimes the icing makes the cake so much more delicious and so much more manageable, right? And we know that treating kids, now these numbers are old. I suspect that the rates, I don't know, Prakash, what the current rates of diagnosis of ADHD medicines are in Australia, but I suspect that they're significantly higher, because this slide comes from Dave Coghill at Don't Forget the Bubbles about 3 years ago. But overall, I think that there's still a huge number of young people with ADHD who have been untreated. And I think a lot of us are getting families walk in through the door asking, could my child have ADHD? And I get a lot of people say to me, do you think that I wish this tsunami of, ADHD diagnosis requests would go away? I actually really relish it. And that's because as a paediatrician, I get the absolute joy of seeing young people who walk back through the door in my clinic after they've started some Ritalin or Vyvanse, in addition to all the psychosocial stuff that we do. So I don't want to say that I never think of medicine as an isolated intervention. The other stuff is so important. But, kids who have been really misunderstood walk back in through the door and say, this is great. For the first time in my life, I can think. I'm getting on with my parent. I've got a lovely 14-year-old who walked in the door the other day, and she said, now, I actually don't care too much about academic results. Like, I want kids to achieve their potential, but I'm not here to make kids get 99% instead of 98%. That's not why I give kids Ritalin. But she walked back through the door and she said with the most incredible confidence and enthusiasm, I am an academic weapon, right? And so for this kid to have gone from a position where she was trying so hard and was underachieving from what she wanted to achieve, to be able to make that transformation, that's a really beautiful story. So we definitely see kids who have side effects to ADHD medications, but we, as paediatricians, medicine in combination with psychosocial interventions can make a really significant difference in the mental health and self-esteem of these young people who we're seeing. This is just some Instagram photos from our practice. We have a lovely team. Please feel free at any point, if you've got any questions, to reach out and ask us either about our model of care or if you've got a kid who you want to chat about, please feel free to hop on the email or hop on the phone and ask us. We're always happy to help answer those questions. Sahar, back to you.
Thank you so much, Vicky. It was so good. And, so thought-provoking in terms of not overly medicalizing things. I'm just gonna go in and go to the next part. Just one sec. So now we're just going to briefly have a look at health pathways. As Vicky was mentioning earlier, that health pathways are a fantastic resource which are written by GP clinical editors with support from local GPs, health hospital-based specialists, and other subject matter specialists, experts. And what's the benefit of health pathways? It kind of provides us a guide to standardized evidence-based medical advice, reduces variation in care, as in one person sitting in one part of the country is trying to practice the same way as the other person, and there is less variation, and gives us a guide on how to refer to the most appropriate hospital, community health service, or allied health provider, and what services are available for your patient. That's a brief overview of how it looks. You can just simply search in. When you actually go in and type ADHD in children and young adults, you would come across as quite a lot of screening tools like Vanderbilt, what Vicky was mentioning earlier. So very helpful and useful, and guides us to what services are available in terms of online and in person. And if you haven't really registered to Health Pathways before, this is a QR code that you can scan and register. It's very easy to use, and you can always give a feedback if you find something that